Hi, my name is Clifford Hudis, and I am the CEO of the American Society of Clinical Oncology, as well as the host of the ASCO in Action podcast. About twice a month, I interview thought leaders in healthcare and experts in oncology, and we provide analysis and commentary on a wide range of cancer policy and practice issues. You can find the ASCO in Action podcast on Apple Podcasts or wherever you are listening to this show. And you can find all 9 of ASCO's podcasts, which cover a wide range of educational and scientific content and offer enriching insight into the world of cancer care at podcast.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all of the shows, including this one, at podcast.asco.org. My name is Shannon McKernan, and today on the ASCO Guidelines podcast, I'm interviewing Dr. Charles Shapiro from Mount Sinai Hospital in New York and Dr. Joe Neuner from the Medical College of Wisconsin-Milwaukee, co-chairs of Management of Osteoporosis in Survivors of Adult Cancers with Non-Metastatic Disease, ASCO Clinical Practice Guideline. Thank you for being here today, Dr. Shapiro and Dr. Neuner.
Thanks a lot. Pleasure to be here.
So first, can you give us a general overview of what this guideline does cover?
This guideline covers very important topics, that of osteoporosis and that of cancer survivorship. And it's a coalescence of these 2 common problems that is the impetus for this guideline. It covers risk factors and what you can do as a cancer survivor to mitigate your risk. It covers screening and identification of the best test to use to measure your bone density. And it covers how to treat or pull the trigger for anti-osteoporosis drugs based on the guidelines that are contained within the document.
And what are the key recommendations for this guideline?
So we developed this guideline with 3 key guideline questions in mind, and they really required a fairly extensive search of the literature to address them. And we did that by looking to some of the literature outside of cancer in osteoporosis screening in other patients as well. So I'll sort of talk about it in terms of the 3 key questions. So the first question we had was, which patients with non-metastatic cancer are at increased risk for developing osteoporotic fractures? So that first question was which patients, are we really addressing in this guideline, and how do we assess whether they're at potentially increased risk? So in response to that, we strongly recommend that oncologists, teaming with other physicians, including primary care doctors like myself, evaluate their patients to determine whether they're high risk. And so we provide a lot of details in an extensive document, but in our bottom line, we have a summary of the most common and the most severe risk factors. And those include things like advanced age, current smoking, excessive alcohol consumption, and a history of prior fractures, so already showing that they're at high risk for fractures. So we recommend you look to that list and then add in your own clinical judgment, particularly about patients who have added risks from their cancer treatments. And so we do also talk about those patients. And in particular, we call out patients with specific anti-cancer therapies. For example, aromatase inhibitors given to breast cancer patients, anti-androgens or GnRH agonists given to breast cancer and prostate cancer patients, and call out how they're at particular risk. And finally, in response to this question, we also recommend that you consider using a risk assessment tool. And here I mentioned that we had to look to the non-cancer literature. So here the WHO actually developed something called the Fracture Risk Assessment Tool, or FRAX. And we do recommend that you use this tool or something like it to help you to assess whether your patient's at high risk. And those are readily available on the web. Search FRAX, F-R-A-X, to use it. And of course, we have links in the guideline. So that addressed the first question, which again was which patients are at increased risk. And we have a list of risk factors that you should be considering and some references, particularly FRAX, to help you with thinking about those risk factors and how important any specific risk factor is. Our second question really dovetailed right on that, and that was, how should patients who are at increased risk, who you've identified as part of that first question, to be at increased risk for osteoporotic fractures, be screened? And here again, we look to, the standard recommendations for patients who don't have cancer as well. And there are two ways that you could move towards should you screen your patient or not. One could be your patient had one of those risk factors that we talked about and are listed in the document. The other is you use that FRAX tool and patients are at more than average risk. And then we recommend patients be screened using one of the standard screening tools. The most common one is called dual X-ray absorptiometry. And I want to specifically mention central dual X-ray absorptiometry, which means that the test is done on the hip and the lumbar spine. Those are readily available. All major medical centers have them, and many clinics have them as well. And so we do recommend that for screening. And then we offer some specifics about how frequently you might screen, because that's another question that often comes up. And so then our final question is, once you've determined that your patient is at high risk because their bone density test and or their FRAX test shows that patients are at high risk, we do encourage talking to them about treatment options. And the first thing I want to say is essentially everyone that our guideline addresses, which is all patients who currently have or who are survivors of non-metastatic cancer, that they should consume a diet with adequate calcium and vitamin D. And so that's generally considered to be 1,000 to 1,200 milligrams of calcium and at least 800 to 1,000 IUs, international units of vitamin D. We also strongly recommend exercises and call out some specifics that you want to work on: balance, flexibility, and resistance if possible, and that you quit smoking and limit alcohol consumption. All very good things for the body generally, but also very good for the bones. Obviously, one of the meat of this guideline is also about pharmacologic interventions specifically. And since Dr. Shapiro treats so many patients with this, I'm going to ask him if he wants to comment further on specifics about pharmacologic treatments when we think patients should get them.
So thanks, Joan. So pharmacologic interventions include ranked ligand inhibitors like denosumab, or IV or oral bisphosphonates. So clearly, if your patient's at risk, that means a hip fracture predicted at 3% or more, or a non-hip vertebral fracture at 20% or more. And you get these numbers from the FRAX calculator and other calculators in common usage. Then you pull the trigger and use one of these agents. Now, we couldn't distinguish between the agents in terms of which one was preferred. It depends on patient preference, comfort with the doctor in terms of how comfortable the doctor is using the agent, and other factors that go into the decision about which bisphosphonate to use. Generally, the IV zonodronic acid and sub-Q denosumab are used in the cancer populations, but oral bisphosphonates can be used as well.
And why is this guideline so important, and how will it change practice?
Well, this guideline is so important because we know from survey studies that osteoporosis and preventing osteoporosis and treating osteoporosis is, in the cancer survivor population, is underutilized. And this is an important point because many people, especially with breast and prostate cancer and colorectal cancer and bone marrow transplants, will be long-term survivors. And we don't want to cure a patient just to have him fracture 10 or 20 years later. So that's the importance of the guideline. So it's a recognition that osteoporosis is treated the same whether you're a cancer survivor or not. But the cancer treatments we use in routine practice can cause osteoporosis and bone loss. And that's the importance of this recommendation, as well as the particulars of who's at risk, the risk factors, screening, and pulling the trigger for treatment. So that's basically, in a nutshell, why this guideline is so important and how it will change practice, because we hope that the guideline stimulates us as health practitioners to screen our patients for osteoporosis, recognize risk factors, and how to pull the trigger on treatment to prevent or treat osteoporosis in this population. It doesn't matter who follows patient but the patient has to know who's going to follow the bone density and treatment for osteoporosis, whether it's comfort that the oncologist has with the whole process of screening and risk factors and pulling the trigger for bisphosphonates or denosumab, or the endocrinologist, the rheumatologist, the primary care physician. The patient's got to know who's going to be responsible for what aspects of care, survivorship care, and this is a big part of survivorship care. So the treatment summary, which is a document that the patients get and is given to the primary care provider, should specify who will take responsibility for what aspects of survivorship care. And this is a big aspect of survivorship care, osteoporosis screening and treatment if necessary. So it doesn't matter who does it as long as it gets done.
I would jump in if I could, Charlie.
Yeah, so please jump in.
So I guess the only other point that I wanted to make about how it might change practice is, osteoporosis guidelines have been out since the late 90s, early 2000s. And so many patients probably have thought about osteoporosis and their risk in the past. But I did want to note that there have been a number of studies in the last 5 years showing that in primary care, so family medicine and in general internal medicine, like I practice, that we're actually ordering fewer bone densities than we did in the past. And all the reasons for that aren't clear. Perhaps it's because of some concerns about the rare side effects of some of these medicines. Perhaps it's because the guidelines aren't clear because the data is not clear about how often we should test people who don't seem to be at high risk once they've had a first test. But nonetheless, there seems to already be some effects of this, that the hip fractures, which had been decreasing, are starting to look like they're rising again. So it really is important then, if we're not going to screen very frequently everybody, that we are screening the people who really need it. And so then this guideline, it calls that out, that these are patients who, because either their cancer treatment and the debilitating nature of that in some cases, or the specific medications puts them at particular risk. Those are the ones that we can't omit this.
Great. Finally, how will these guideline recommendations affect patients?
I think we're hoping that this will help in the care of cancer survivors and spark people to use things like survivorship care plans, or if those don't work in your institution, other ways to make clear what the patients who are survivors are at risk for, both related to their cancer and outside their cancer, so that we can all work as teams of healthcare providers to make sure all of the things on those lists get addressed. So we're hoping that with some very clear recommendations about how to address bone health, that we can help those teams serve patients best they can. Obviously, it can also provide some really essential information for patients who are wondering what the things they need to be wondering about in this new phase of survivorship after cancer that they're dealing with.
Dr. Shapiro, did you have anything to add to that question?
Hopefully, we can prevent fractures in our cancer survivors by following these guidelines. It's really important that we prevent osteoporosis and hip fractures and vertebral fractures, because we don't want to cure the patient just to saddle them with an osteoporosis and breaking a hip or breaking a vertebral body 10 or 20 years down the line. So this will hopefully affect patients positively, and we intended the guideline to be for patients in terms of risk factors, and if you need a bisphosphonate or an anti-osteoporosis drug, then it's clear indications in the document who gets it and who doesn't. So I think that the effect, we hope, would be great on patients, that part of general health is osteoporosis screening. And just because you're a cancer patient doesn't absolve you from participating in all the health recommendations, including osteoporosis screening.
As with all ASCO survivorship guidelines, we do hope that this one informs many conversations between patients, survivors, and providers. Thanks to your overview here today and your work on this guideline, more clinicians will be informed of the risk factors and possible interventions for osteoporosis and survivors of non-metastatic cancers. So I want to thank you both for coming on the podcast to discuss this guideline with me today.
Thanks for having us.
Yes, thank you.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/survivorship-guidelines. And if you've enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.